So it's my job to cover all of minimally invasive valve surgery in 20 minutes. We often have week-long conferences for this, so I'll do my best here today. Get the timer going. Great. So I'm going to discuss the current state where we are in surgery with minimally invasive valve surgery. That's primarily aortic and mitral operations. Those are the vast majority of minimally invasive surgery that we do. Compare it to our conventional surgical operations. Talk a bit about the advent of our new sutureless valves, and then touch on transcatheter valve technology just a tiny bit. That's a whole different topic that we certainly don't have time for. Any incision you can think of has been attempted with minimally invasive valve surgery. Basically, when we talk about our techniques, it's either mini sternotomy, so upper or lower half, and then mini thoracotomy. Most of the transverse incisions and peristernal operations have really been abandoned. They're not quite as effective for our techniques and for healing. So just to give you an idea of the landscape currently, a multi-center review of expert techniques for minimally invasive surgery was published this year for aortic valve replacement. The primary two incisions are right anterior thoracotomy and upper half mini sternotomy for the best access to the aortic valve and root. It's been recognized now careful preoperative screening is required, including risk factors for all types of cardiac surgery. But for these patients, most get a chest CT to help identify the actual location and orientation of that valve and guide incisions. So a chest CT here, you can see the calcification in a patient with aortic stenosis. That's a midline and sort of a deeper location for the valve, so a mini sternotomy would be ideal for that patient, especially if there's associated aortic pathology. Right anterior thoracotomy for a mini AVR is suitable for patients where the aorta tends to be more to the right and the valve is a little bit higher in the chest for adequate access. Now, the Leipzig group has been the pioneers in both aortic and minimally invasive mitral surgery. Their publication last year analyzed nearly 4,000 minimally invasive mitral operations and sort of gives us the concept of the learning curve and how institutions and surgeons learn this type of surgery. They carry a prospective database. They do a procedure in only one way for mitral valve surgery. It's anterior thoracotomy with peripheral cannulation. And they've looked very closely at how this has evolved over the years. There's clearly a tendency for better results as surgeons gain experience with the operation, as the institution also gains experience. So they noted at the beginning of the experience, about a quarter of the patients will have an adverse event. It declines to about 10% as the operative experience increases, and the institutional learning curve will decline as well. But as you add a new surgeon that has to learn those techniques, it's expected that adverse events will rise until that surgeon gains that experience. And they actually recommend about 100 operations for an individual to overcome that learning curve, and at least 50 operations a year to sort of maintain the optimal results. So this is the most experienced center in the world for this kind of surgery, and you can see here, as they add a surgeon, there's this little bump in the adverse events that occur as that surgeon learns to overcome and become more familiar with the technique. So let's move to just talking about aortic valve replacement. So minimally invasive approach versus conventional approach. The group from Italy, propensity analysis of about 360 isolated aortic valve patients. The technique was absolutely the same. It was just the incision that varied. So full sternotomy versus a right anterior thoracotomy or upper mini sternotomy all had stented valves implanted with interrupted sutures in the standard technique. A little bit longer cross-clamp time and a little bit longer bypass time in the minimally invasive group as expected, but the mortality was equivalent. So these are excellent results in mortality, about 1.5%. No difference in all the other standard complications. Shorter ventilation, reduced transfusion and atrial fibrillation rates in the minimally invasive group. Same group then did a retrospective review comparing their patients just having minimally invasive surgery, so mini thoracotomy versus mini sternotomy. Over 400 patients. All of these were considered for mini thoracotomy, but were treated with upper hemisternotomy if they had prior surgery or had either a valve that was pushed to the left or a valve that was quite deep, and that would be appropriate therapy. And again, the 5-year mortality is equivalent, hospital mortality equivalent, major complications basically the same. So excellent results in a large number of patients. The group from Germany compared their minimally invasive experience with their conventional AVR group. 800 patients matched in a propensity method. All had upper or full sternotomy, so all had central cannulation and standard valve replacement. Equivalent outcomes, only a slightly longer cross-clamp and operative times in the minimally invasive group, so as they gained more experience, it was just as efficient as doing the standard operation, an equivalent duration of hospitalization. And then finally, the Leipzig group this year published their experience with over 2,000 isolated valve replacements over a 9-year period. So this is the first real long-term outcome data we have for minimally invasive aortic valve replacement. Nearly 500 minimally invasive patients, propensity matched. As expected, the minimally invasive group was a little bit younger, had a lower Euro score, so a lower risk population. But look at the mortality here, 0.4%. There's very few studies of aortic valve replacement that have that kind of excellent outcome. And they also showed improved long-term survival. So these are stellar results in a very experienced center, but you can see this 80% 8-year survival is excellent. And then finally, a meta-analysis also came out this year looking at minimally invasive AVR operations compared with conventional AVR, nearly 13,000 patients. It was sort of a heterogeneous population, a wide number of studies, but they did a good analysis here. Basically, the operative times and bypass times tend to be a little bit longer in the minimally invasive group, but if you look at the randomized controlled trials, they're basically equivalent. There's no difference in the outcomes, and again, reinforcing the reduced transfusion, ICU stay, and major complications in the minimally invasive patients. So now moving over to sutureless valves. These have come onto the market in the past few years, currently in trials. These are valves that are put in without sutures at the annulus. It's maybe 1 or 2 or 3 sutures to lower this prosthesis into place, and then it's on a stent. And so that stent is deployed in an open fashion within the aortic annulus after the valve is removed and the calcium is removed from the annulus. So this is a retrospective review from a combined series in Italy and Germany. Right mini thoracotomy, upper hemisternotomy for either standard minimally invasive sutured valve versus this Percival S sutureless valve. As expected, sort of a older population with a Euro score of about 8 mean value. Cross-clamp times are listed there. The 1-year survival is excellent. So again, look at these excellent outcomes and mortality, 0.7%, low stroke rate, low pacemaker implantation, and so these sutureless valves have some important promise here. The group from Italy also looked at about 500 patients through a right anterior mini thoracotomy, so a little different incision approach. About 250 patients in each arm, standard AVR versus the sutureless valve, then propensity matched pairs within that group. Again, excellent mortality of about 1% after aortic valve replacement. Interestingly, they were able to put in a little bit larger prosthesis with the sutureless valve, and that's probably due to the stent expansion of the aortic annulus. But here's their data. As you get out here, not very many patients, but look here at about 2 years, this sutureless valve group has excellent survival. So again, these are promising new valves for minimally invasive techniques. And then finally, a propensity match review out of Germany of a 2-year experience with sutureless versus transcatheter valves. So we all talk about transcatheter valves being the new advent and possibly replacing standard surgical techniques. Well, they propensity matched 120 patients in each arm. The Euro score quite a bit higher in the TAVI group as expected, and then it was a Percival sutureless valve for the operative patients and a Sapien valve for the transcatheter ones. Look at the mortality here, 0% in the sutureless aortic valve replacement group versus 8% in the TAVI group. Equivalent stroke rates, a little higher pacemaker group for the sutureless group, probably due to that stent expansion in the debrided annulus. But obviously more paravalvular leak in the transcatheter group, and the decreased survival over time was almost entirely due to that paravalvular leak that occurs in the transcatheter valves. So again, the early drop-off here is just to that early mortality, but as that sutureless valve goes along with time, there's no ongoing mortality. So very promising new technology for aortic valve replacement. Let's move over to mitral valve, minimally invasive surgery. So the two groups here are Boston and again Leipzig. The Boston group did a retrospective review of 15 years experience with isolated mitral valve operations. Over 3,000 and 1,000 of these were minimally invasive. The vast majority had mitral repair, most done either through lower half sternotomy or peristernal incision. Very low rate of complications, which is what should be expected with mitral valve repair, mortality less than 1%, low stroke rate, and excellent freedom from reoperation, as should be expected compared to standard mitral valve replacement, so 90% freedom from reoperation. A Leipzig group, again, over nearly 3,500 cases of minimally invasive mitral valve surgery. Most of these were repairs. They have a standardized operative technique through a right thoracotomy with peripheral cannulation and direct cross-clamping and antegrade cardioplegia. Again, identical operative mortality, less than 1%, identical stroke rate, a little bit higher length of stay in the hospital, but again, equivalent 10-year freedom from reoperation, which is what should be expected from a standard mitral valve repair, over 90% at 10 years. And then, so the Penn group did a propensity evaluation now, comparing minimally invasive mitral valve surgery with conventional. Over 1,000 mitral repairs, no difference in the major outcomes, less transfusion, less postoperative mitral regurgitation in the minimally invasive group, and importantly, equivalent repair rates and no difference in long-term survival. So again, these excellent results with the minimally invasive approach, identical basically to open mitral valve repair. A meta-analysis was published this year, again looking at minimally invasive mitral valve compared to conventional mitral valve surgery. A lot of reports, only 7 of these were really appropriate for analysis, but nearly 2,000 patients. Various techniques were used, but all done through anterior right thoracotomy. Again, the outcomes are essentially equivalent. No difference in mortality, no difference in stroke, a little bit longer operative and bypass times in the minimally invasive groups, but the repair rates are essentially equivalent. And again, 2 different statistical analyses here, but notice that the overlap is basically right in the middle. So minimally invasive mitral valve surgery is equivalent to conventional mitral surgery. Robotic mitral techniques, I mentioned earlier, have been started in coronary bypass grafting, more widely adopted, although not widely embraced for mitral valve surgery. So multi-center review of current literature. There's been about nearly 30 studies, but none of these are randomized controls. None of these are propensity matched. They're basically just observational, usually single-center studies of their experience. Most of the patients tend to be very healthy, quite young, have few comorbidities, but all types of mitral pathology can be addressed. So this is something that has been utilized, and we don't have any long-term data, unfortunately, on robotic mitral surgery. Cross-clamp times and bypass times are generally longer. That does tend to persist even with operative and institutional experience. And then finally, the Austria group published last year their experience with about 800 patients using what's known as endoscopic surgery. So it's not robotically based. It's a minimally invasive incision, and it's all done through video-assisted techniques. The instrumentation goes to the main incision, but again, it's all done on a screen-based approach. They had excellent results, able to repair the vast majority of patients, very low mortality, so equivalent to other forms of minimally invasive surgery and conventional mitral surgery. So again, very low stroke rate there, 0.2%. Death rate 2%, stroke rate 0.6%. So another promising approach for minimally invasive mitral surgery. And then finally, just a couple of comments. One of the major struggles in cardiac surgery is a patient that has combined valvular and coronary disease. And we know whether it's aortic or mitral disease, addition of coronary bypass can double that operative mortality. So a new study just came out this year looking at over 200 patients trying to ameliorate the complications of this combined disease. So percutaneous coronary intervention followed by minimally invasive valve operation. It's not typically hybrid, it's more of a staged procedure where they usually have their percutaneous intervention performed first and then come back for the minimally invasive valve operation in an elective setting. Median time interval really in this study was about a month. Most of these were single vessel and most of the patients had drug-eluting stents. Well, they had excellent results. The hospital mortality was about half of what we expected, so 3.5%, which is really what a standard aortic valve replacement mortality would be. Low stroke rate, lower re-exploration for bleeding, was a little bit higher transfusion rate, about double in patients that had clopidogrel preoperatively for their stenting, but the cumulative risk, importantly, was lower than would be expected with a concomitant aortic valve replacement and coronary bypass. So very encouraging results for the sort of hybrid staged approach. And again, here's their follow-up outcomes. And when they went out to about a year, most of these patients requiring some rehospitalization or another procedure was for the coronary portion of their disease rather than the valvular portion. So in conclusion, minimally invasive valve operations have excellent outcomes that are equivalent to our current techniques for standard valve replacement and repair. There is a distinct learning curve, however, for minimally invasive valve surgery, so institutions and physicians that are considering adopting this to their practice need to be willing to invest time and resources and patience to achieve the expected outcomes. Our ongoing valve technology is expanding now with sutureless valves and transcatheter valves that will evolve, and surgeons and all heart teams need to be willing to adapt and evolve with that technology. And the important thing now is our heart team approach can help us specifically address each individual patient. We now have treatment options available for multiple patients and multiple valve pathologies. So standard aortic valve and mitral valve operations now sutureless, minimally invasive operations now transcatheter, all based on the comorbidities and particular patient profile for each individual that comes to our care. Thank you.